Hi, I'm Dr. Ruchi Gupta. I'm Associate Professor of Pediatrics at Northwestern Feinberg School of Medicine and Lurie Children's Hospital in Chicago. Our manuscript is entitled Childhood Food Allergies, Current Diagnosis, Treatment, and Management Strategies, which is published in the May issue of Mayo Clinic Proceedings. First, I'd like to thank my esteemed co-authors, Ashley Dyer, Namrata Jain, and Dr. Matthew Greenhut, for all their work on this manuscript. Now, the purpose of this review is to aid clinicians in translating the guidelines, the food allergy NIAID guidelines that were recently published, into primary care practice, and includes 6 content domains. Now, food allergy in the U.S. impacts 8% of children, which is about 1 in 13 kids, and it's been increasing during the past decade. The most common food allergens are to milk, egg, wheat, soy, peanut, tree nut, fish, and shellfish. Now, food allergy is defined as an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a specific food. Symptoms typically present within minutes to hours after ingestion. Now, food allergy is an immune-mediated response, most commonly IgE, and food intolerance is a non-immunologic response to a particular type of food. An example of an intolerance is lactose intolerance. As stated earlier, food allergy is a rapidly emerging public health issue that affects an estimated 6 million U.S. children. A recent study has also found that about 30% of these children with a reported food allergy have more than one food allergy, so they may be allergic to nuts, egg, and milk, which makes it more difficult to avoid. The 5 steps for management for primary care physicians include: first, clinical history and diagnosis; second, testing; third, medications; fourth, counseling; and fifth, allergy referral. Now, first, for clinical history and diagnosis, it is very critical that primary care physicians chart 2 things. 1, what type of food a child may have eaten to cause the allergic reaction. And 2, what type of reaction the child had after the ingestion, and be as specific as possible. Reactions can range from mild symptoms, so documenting mild hives, itching, some nausea and discomfort, to severe symptoms, drop in blood pressure, diffuse hives, shortness of breath, throat swelling, trouble breathing, fainting. It is very critical to document both of these when charting. Second, testing. There are 3 types of tests used for food allergy diagnosis. First is the blood IgE to a specific food. Second is skin prick tests. And third is the oral food challenge. The one most commonly done by primary care physicians is a food-specific IgE. Now here I must note that it is important to do food-specific IgE, so an IgE specific to peanut, instead of the panels that are often available. Panels are difficult because they often lead to unnecessary avoidance. Many children do have positive testing, yet do not display signs and symptoms of the food allergy. Number 3, medications. Now, all children suspected of having a food allergy should be prescribed 2 types of medications. First, an antihistamine, and this should be used only for mild reactions, a few hives or itching. And then second, an epinephrine auto-injector device. And this should be prescribed for any reactions where it involves 2 systems or any severe reactions. Now, EpiPens and Auvi-Q are the 2 types of epinephrine auto-injectors currently on the market, and they both have 2 versions. One is the regular Auvi-Q or regular EpiPen for children who are greater than or equal to 30 kilograms, and the Auvi-Q Junior or the EpiPen Junior for children between 15 and 29 kilograms. So fourth, counseling. Now, comprehensive counseling is needed for all families with a child with food allergy. There's 6 areas that families should be counseled in. First, food avoidance and appropriate nutritional monitoring. 2, label reading. This is critical as labels are very difficult to read with the may contain and manufactured in places that contain labels. 3, recognition of the signs and symptoms of anaphylaxis. 4, how and when to use an epinephrine auto-injector. 5. Appropriate follow-up, and 6. Documentation for schools. All children with food allergy should have a food allergy action plan. This is available on websites such as the one for food allergy research and education, which is www.foodallergy.org. Finally, the 5th step for management is to provide a referral to an allergist. This is where they will be able to get the skin prick test and potentially an oral food challenge, and the allergist will be able to continue to guide them in the care of their food allergy. Finally, future directions. So, as food allergies grow, so does the research, and the research around looking for a treatment or a cure. Now, there have been several potential therapeutic modalities that are being investigated and include oral immunotherapy, sublingual immunotherapy, and Chinese herbal medicine. Food allergy is a growing problem in the United States, with 8% of children affected. 40% of these kids have had a severe reaction, and over 30% are allergic to more than one food. Until we find a cure or a treatment for these children, improving food allergy management by the primary care physician is critical. Thank you so much.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.